What are the recent developments on food anaphylaxis?
I think the recent trends is that food allergy is becoming more prevalent whatever part of the world you are looking at. In fact, it's reached the prevalence of about 8% in children and 5% in adults. And we're seeing the trend in children earlier and earlier, even below 12 months of age. And the foods that are gaining in numbers are peanuts and tree nuts. We still do see a lot of milk and egg allergy in the young child, but the peanut is also starting at a very young age. And we are reminded that 92% of fatalities occur with peanut or tree nuts. We also have a newly recognized syndrome, and that is delayed meat anaphylaxis. So this is between 2 and 5 hours after ingesting like meat, beef, pork, or even lamb or gelatin products from one of those animals. Then you will start to have anaphylactic symptoms. This is hard to recognize. Using commercial prick testing will fail to give you the diagnosis. You actually, in the office, can take a fresh piece of uncooked meat and do a prick test and have a positive result. Or you could obtain a blood test and look for alpha-gal, which is the sugar allergen that's causing the reaction, or look for the specific meat that is causing the reaction. So these are some of the newer ideas that are coming about in food-induced anaphylaxis.
What is your message for patients with food anaphylaxis?
The message for patients is once your allergist has diagnosed that particular food, you must avoid it. And avoidance is not always easy. And it means reading labels. And if that product says may contain or made in a factory with, then you must avoid that food. We find that up to 42% of the time, there is evidence of that food in that product. So you can't just think maybe it will be safe. That's one message. The second message is that there is no way to predict when a mild allergic reaction to your known allergen starts to occur, how severe it will be. There's only one drug that will prevent progression and save your life, and that is epinephrine. You do not want to use an antihistamine such as Benadryl. That does nothing but relieve itching and hives. It will not reduce airway swelling, and it will not cause a reversal of anaphylaxis. That's the biggest mistake we see made not only by patients but by physicians. Even emergency room doctors often give an antihistamine or a steroid, which is very long onset of action. It's going to take 4 hours before that steroid works, even if it helps. It is epinephrine that you must use, sometimes even a second dose in very severe cases if you are not responding.
What is the take-home message for allergists and primary care physicians who take care of patients with food anaphylaxis?
Again, it is to educate the patient on how to recognize when they are ingesting that food or when they may be, to emphasize that they must always carry their auto-injector, because just because they think they are avoiding it, restaurants and social events are known to have contaminated products, and they may indeed have an allergic reaction. We also are now gathering some very good data on the positive predictive value, where maybe you don't always have to do an oral challenge. Some of the interesting data on very young children below the age of 12 months of age is indicating even without ingestion, there may be a prick test or a specific IgE in an at-risk patient that is high enough that that patient does need to avoid the food, and you don't even need to do an oral challenge. But certainly, oral challenges should be done in the office when there's any question. When you think that patient is outgrowing the allergen, we know that 89% of the time, the patient will pass the food challenge, and they can then add that back to the diet. And from an emotional, psychological point of view, doing the food challenge helps regardless of the outcome. Whether the patient is positive or negative, it reassures and it gives them the information they need. And less than 2% of the time will you actually need to use epinephrine. So it's a safe procedure, it improves quality of life, and I encourage all of you to engage in that in your office.
Where is the research on food anaphylaxis heading in the future?
I think the research is for component resolved diagnosis, where we can be more accurate with saying which particular foods will cause mild reactions and which will cause more severe life-threatening reactions. Currently, most areas of the world only have available peanut, milk, and egg to help determine that, but it is in research available for many other foods, vegetables, fruits, nuts, and will become more commercially available as we move forward. We also are doing more basic research in anaphylaxis, recognizing why actually most people survive is probably the endogenous release of epinephrine rather than, it's certainly not the antihistamine that's saving their life, which is the misconception, but it may be endogenous release. So as we learn more about it, the other interesting area of research is why does having alcohol or why does having NSAIDs play such a role in increasing anaphylaxis maybe to foods, to exercise, and to other items. So the comorbidities of adding various components together to increase the risk. Fever, for example, may increase the risk of a reaction if you ingest that particular food allergen. So these are some of the areas that research is going in.